Thanks everybody for joining. This is Carol from the STS. This is the Quality Improvement Series webinar on decreasing vent times. Today on the webinar with us, we have Diana Lejo from Johns Hopkins, who's going to report on the reporting dashboards, which if you joined us for our first Quality Improvement Series webinar where we had Dr. Glenn Whitman, he touched on that in their very useful and impactful reporting dashboards. Diane is a mastermind behind those, and she's going to go over those dashboards, how they built them, and their usefulness at Hopkins. When she goes over the dashboards, for those who are watching live, you'll be able to see this live. In the recording, we're going to stop recording or cut that out from the recording because there'll be live information on there. No PHI, but we just didn't want to share out live information recorded, posted on our YouTube channel. So just be aware that if you are listening, there'll be a section of this that seems missing, but it's intentional. So, and I'm going to go to, oh, and this is their first Chi ride all together. They did great. They all slept. Okay. So also on the line with me today, we have, in addition to Diane from Johns Hopkins, we have Addie Dolan, Emily Conrad, Melinda Offer, and Sydney Clinton, and myself. Leanne is on vacation. She has a big birthday coming up tomorrow, so she's not able to join us today. Important dates for adult cardiac. We have our Quality Improvement Series webinar today. We have a monthly webinar on August 2nd at 2 p.m. Central Time. We have another database Quality Improvement Series webinar on August 16th. August 18th is Harvest 3 close. Don't forget, that's a star ratings period. Please get your data in early and often. Hopefully you're getting close to being prepared for just finishing up collecting those last 2 weeks of cases, 30-day follow-up from the end of June, and you're getting close to being set for Harvest 3 close ahead of time. August 22nd, the opt-out ends for Harvest 3. And then just 2 updates for me. The first one was the Harvest 2 was released. So that is in the IQVIA platform. You can access those reports now. Remember, that is not a star ratings period. So it's just the updates to the risk adjusted and the benchmarked and the NQF outcomes that you'll see in the anesthesia reports if you participate in anesthesia. The other item I wanted to speak on was two emails were sent out. One was specific to exclusion updates for adult cardiac, and the other was the Harvest 2 release, which included information about the exclusion updates. This is really nothing to be alarmed about. What it's saying is that if you have not submitted any new records since the last harvest, for Harvest 2 and 3 or 2 and 4, you will not be included. You'll be excluded from the next harvest. Just because if there's no new data, there's no new data means there's no reason to include you in those analyses, and we don't want to diminish your N over that next 3 months in analysis. So for example, for Harvest 3, which is coming up, if you haven't submitted, which is a star rating, if you haven't submitted any new cases with OR dates for the first 6 months of the year from January 1st through June 30th of 2023, if there's no new data in the warehouse, you'll be excluded from analysis. For Harvest 2 and 4, we're looking at just the 3 months prior. So for Harvest 4, which is data through September 30th of 2023, if you do not submit any new cases from July 1st through September 30th, which is that new period that'll be included from between Harvest 3 and 4, if you do not submit any new cases, you will not be included in analysis. And it's just to make sure that the denominators are correct for the cases, both for the STS aggregate and that the site data is meaningful in what we give back to you. So before we hand it over to Diane, I'm just going to take the one question that came in for me, and then we'll hand it over to Diane for her presentation. The question is, where can you find volume requirements for star ratings? There's a national report overview posted in the IQVIA platform underneath the resource library. You'll find the requirements within that document. All right. So now I'm going to hand it over to Diane. Diane, thank you so much for joining us today in the STS Quality Improvement Series webinar on decreasing ventilation times. Diane is the Director of Informatics at Johns Hopkins Hospital. Thanks again, Diane, and look forward to your presentation.
Thank you, everyone. Can you all see my slides?
Yes, we can see your slides.
Okay. Well, I'd just like to thank the STS and my colleagues and friends around the country for the opportunity to share the work that me and my team do at Johns Hopkins. And so Carol asked me to give sort of a high-level overview of quality dashboards. So I have a PowerPoint that I'm going to kind of go through, and then at the end I can do a live dashboard. I didn't want to do it live in the event of an internet glitch. So this is sort of a safe way of making sure I can cover all the material. So the objectives really for today were to understand the purpose of why we built these dashboards. It's really for quality monitoring and process improvement. We use the data for signaling. We actually meet weekly for an M&M report. We're very fortunate to have Dr. Whitman as our physician champion, and the STS data team meet with him every Wednesday at 11 a.m. To go over the dashboard and the upcoming material for the next day M&M report. So some of this data is important to be able to accumulate and refresh on a basis that the data is meaningful. And then just to kind of review our process and how we came about developing the dashboard. We identified our data sources as using EMR data and STS registry data. We do use Epic at Johns Hopkins, so that's really our electronic medical record. And then we really focus on data quality, using EMR data directly to populate on a dashboard. You have to monitor the quality of the data just because it's coming from flow sheet data in the EMR. We have to come up with some mitigation strategies and validate the data because we're a teaching institution, and usually in July and August, there's a refresh of new residents, and there's often variability of documentation in the EMR. And so if different flow sheets are used among the different providers, it can offset reporting. It's really important to do a data dictionary and maintain your data dictionary, and then maintain your refresh rates and publish your refresh rates so that any assumptions you make about the data, you'll realize whether it's either a day old, a week old, or quarterly. And then we have in our HVI really a data governance council where we talk about data access and permission management and the ability to use the data. Our dashboards are not used for research, and that strictly goes back to some of the validation that needs to be done for research. So this is really used to monitor and provide signals of where our data what our data results and metrics are going. And then I'm going to do a dashboard demo and then some questions. So to get started, this is just I put together with the help of our programmer who actually does all this magic. So I can't take credit for this. This is all programming that I don't do, but my team, really, we work together as a team and collaborate. So in the first column is really the dashboards are based off of EMR reporting. And so in the EMR, there is a transactional system, which we don't have access to. That's what actually populates the EMR. But out of the transactional system, there is a SQL reporting database that takes data from the transactional system and stores it into different tables. And these are just a few of the tables that my team has access to. And so we look at the OR logs to identify the surgical cohort. We look at encounters, admissions, discharges, transitioning from the OR to the ICU to the step down. We pull in demographics, labs, flow sheet data, and ADT data. In addition to using this whole process here for our dashboards, we also use this workflow to extract data out of our EMR and to upload it to our STS registry, where our data managers will then review and abstract the remainder chart. I'm not going to talk about that today. So we have in surgery this CS staging database, and it's a SQL database. And basically, we identify our cohort, and we don't pull all of the data in Epic into here. We only pull the data on our cardiac surgery patients. And we identify them by a cardiac surgeon who's involved in the case. So we have a case list with some operative information. We pull the procedures out of the op time, which is in Epic. We pull a lot of personnel data, who the surgeon, the resident, the PA, perfusionist. We pull some perfusion times. And then we also extract about 60 or 70 labs into a lab table. We usually go 30 days prior to admission, 60 to 90 days post. We actually use these tables for research if it's an IRB approved research or QA project. And then some flow sheets, and this is just a few, but we pull temperature data, chest tube output. This was a really complicated query to make. And so some of this data comes, from our SQL staging database directly to the dashboards over here. This case list view is really what we use to populate the cohort in order to generate these dashboards. And because we want to slice and dice our dashboard around the STS risk bucketed procedures, our data manager will go in and connect to the SQL database, and you can connect to it either through an Excel file or an Access database. And it basically pulls the data down from this database, and then our data manager sort of curates this list and does a procedural assignment of the procedures in Epic from OpTime and sort of maps them over to procedure buckets that we use as filters in the STS database. So a lot of these dashboards, they're coming directly from Epic, but really indirectly because they're ported over to a staging database, and then we aggregate our reporting around the staging database. And we use this intermediate step because it's a weekly M&M report. This is run weekly, and we go back and our data manager will code the prior week's case. We also have an STS data extract that we get from our vendor software that we are using to build dashboards, where we really want to slice the dice, the data a little bit more for QI projects. It's much more granular than what we can get out of IQVIA. We tend to go to a simple approach. So basically we export it into Excel, and then our Tableau developers actually aggregate and develop these dashboards around this Excel spreadsheet. And every quarter, when we harvest data to the STS, we populate this data set to update and refresh the dashboard. And then because we have limited resources and we can't put everything in Tableau or repurpose other metrics that exist in other reports, we also have some sort of blank pages in Tableau where we copy sort of screenshots of static reports of different STS metrics that we don't report sort of from our STS data, but from the IQVIA platform. We're part of a regional collaborative, the Maryland Cardiac Surgery Quality Initiative. We look at their data within our dashboard. We use STS data for OPPE, which are ongoing provider performance metrics. And then Dr. Whitman has a list of CV-SICU. He has a checklist, and he likes to monitor the completion of these checklists. So this is sort of the high-level framework of how we created and maintain this database. What's really important is a data dictionary. And so our developers, there's sort of a templated process before you can publish a dashboard. You have to make sure you have a data dictionary, and the data dictionary has to define the metric. It has to provide the source of the metric. And a dashboard, in our case, may have multiple sources. You have to include the contemporary, the data framework in terms of how, what cohort and how recent that cohort is reflected in the metric. So it includes data through. And you'll notice that some of these dates are different because some of our extracts are run at different intervals. Our lab extracts are run monthly, and the parameters are built upon what the metric is and how the data is reported. Our dashboard is refreshed every Tuesday night. And then it's available for Wednesday when we meet, and then for Thursday for our M&M.
I do have a couple questions for you. If you're okay with answering questions, I can go
Sure.
through them. Okay.
Absolutely.
First question is, and I'm just going to share my screen here just to hold on one second and pull up the PowerPoint slide. There we go. Okay. First question is, can you see the Diane Alejo, Director of Informatics screen, or can you see the?
Yes.
Okay. Who do you use for your third-party vendor? Where does that data get abstracted into before being harvested to IQVIA?
Okay, so I actually have another slide deck that, and I did a talk at STS, AQO, and a poster. But we have ARMIS is our adult cardiac surgery database and thoracic surgery database. And for our congenital database, we use another vendor. So what we do is we use that framework where we go into Epic Clarity and we have code to pull out STS fields that we feel are they're discrete fields. And so there's about 72 fields that we pull out of Clarity into our staging database. And then our programmer wrote code that we upload that data into ARMIS. There's a process that we do that. And I did present a poster where we looked at, we compared the data that we abstracted with, manually with an extract and did a comparison. And then we also extracted data from Epic, imported into ARMIS, and then we did a comparison to find out what was changed after it was imported. Because remember, our data managers review all of that data. And some of the data we pull over is demographics, insurance. There's a translation table to map it to the STS fields. We pull in lab data. We pull in some custom fields like procedures. And then our data team reviews that and completes the record, and they mark it whether it's an STS index case or not. All cases are imported. But not all of them are. The whole STS record is abstracted. For the non-index cases, only the data that comes through and uploaded is completed. The data managers may complete a few custom fields on them, but it's typically, we don't really complete an STS cardiac form, data form on the non-index cases. Did that answer your question? I hope. And we kind of did a timed analysis on our first pass, and it saves about 15 minutes per record by importing. We only import pre-op and intra-op data. We are going to extend it to some post-op data, but we're not there yet. Some of the things that are imported and then revised are, say, outside labs that are found in like the media tab, where the data managers might get a lab result that's closer to the surgery date. So that all of that data is reviewed. But, the data managers, the feedback that I've gotten is they love it, that actually it starts the case for them. And they basically just have to mark it off, whether it needs to be abstracted and by the index case. So we kind of use that process for our dashboards and for the extract.
That's very cool. I'm sorry if I was muted. I said yes. That was I thought you covered that answer very well. The I'm sure your data managers love having it right there in front of them, and then they just verify, right, what's there, or just, check the extra data that's available for them to abstract from, to make sure nothing's being missed, and that it's all correct.
And it's an iterative process. I mean, we get sort of an adjudication process with the vendor of how many records were uploaded. So we monitor that. We've actually, and I'm going to use the word optimize Epic, because there were some fields that the data managers had trouble finding because it's not well documented in the EMR, like AFib on arrival to the OR. So
Yeah.
our data managers are great. They work with the clinical team and educate them. And we worked with Epic so that we've created some fields within the documentation. In our H&P, we have some STS fields. In our discharge summary, we have STS fields, and our operative note. And then Dr. Whitman is such a physician champion. There is and sort of an admitting ICU admission note, and for not just STS documentation, but also MHAC documentation and other hospital-wide quality requirements. It's a pre-canned list that his team, the CVCQ intensivists, consistently use to help get documents, to get the data really documented well. And then just a plug for our data managers. At our M&M, residents and our surgeons attend it, and we've kind of baked in now some education where we have sort of an STS field of the week. And so there's education about, what is COPD, how STS defines COPD, for example, or it's probably not a good, or cardiogenic shock.
Yeah.
Or, so it's kind of a definition of the week. And
that's pretty cool.
Yeah. And so while we're discussing this, because sometimes, when there's a mortality, there's a phase of care. We use that phase of care mortality out of Michigan, and we have a dashboard on that. And so the data managers, while all the cases discussed and events that occur either, in the pre-op phase, intra-op, or post phase, they're there to hear the complications and the post-operative events. And, they question, is this a stroke? Is this an STS risk adjusted case or an other case? So,
how often do you have those? How are your M&Ms monthly?
Weekly. And that's why we needed this process where the data team sort of curates that cohort list to put the patients based on their procedure in Epic into an STS risk bucket. So that's done on a Monday for the prior week's cases.
Okay. Yep.
Right?
So you are doing it, and everything is pretty much real time.
Yes. Well, the extracts and all, the programmers, some of them are automated and some of them they manually run monthly because we were updating and adding more fields. But and then on Tuesday night, the dashboard's refreshed so that it's available Wednesday for the data team to meet with Dr. Whitman. And then on Thursday morning at 7:30, we have an M&M. So
wow.
And then in our M&M, we also track other metrics like multiple arterial graphing. We look at re-ops for bleed. They review all the op notes and determine whether or not a bleeder can be found. So these are some of the other things that our data managers track. And that's done, weekly. They discuss coding questions with Dr. Whitman. We tell surgeons they need to go back and fix an op note or they don't have an op note. So we're very proactive in trying to make the documentation better and trying to get really clean, accurate data. And then we have a phenomenal data cleanup process. Our data manager presented that at AQO last year on how we validate data with EMR extracts to make sure we didn't miss anything. A pretty comprehensive process.
Yeah, and it sounds like you really have to have great surgeon involvement. And I know Dr. Whitman um, is probably one of the best surgeons for STS advocation. He's a great advocate, right, for STS, and I'm sure he worked very hard to get all of the surgeons on board. But did you have any hurdles in getting, or do you have any hurdles in getting? I'm sure you have new surgeons in there. I'm sure you have surgeon rotation. You have your base set of surgeons, and then you have, I'm sure, surgeons that sometimes are rotating in and out of there. Is it
Yeah.
hard to get new surgeons?
So that's a great question. We talk about this all the time. We have new surgeons and old surgeons, and we have surgeon worksheets. And so our data team collects them from the OR. We actually have a couple worksheets. Some of them are timeout worksheets that we collect for other reasons. We actually had a worksheet where they document why they didn't use multiple arterial grafting. But we do have surgeon worksheets. They were we used the STS templates and modified them. We needed to organize them. They were very long and the surgeons weren't really completing them because the diagnosis data was on one page, the operative data was on another page. So we kind of said, if you're going to work on if you're going to operate on an aortic valve, put the diagnoses and the procedure together. It just sort of, the workflow was better. And so we've changed our surgeon week worksheets many times. And they're picked up and they're scanned into a network drive. And then when the abstractors enter the STS records, they review them. If they're incomplete, they're sent back to the surgeon and the surgeon needs to complete it. And if they don't, then Dr. Whitman will reach out and put some nudging, I should say, for them to complete the worksheet. I have to say, our operative notes now compared to 10 and 15 years ago are done much more timely. And so that really,
I bet they are. I bet they are.
It's not always been that way. There sort of one or two, their OpNet may not be complete for a week or two. But now they're usually done the same day, sometimes before they walk out of the OR. And so we really don't have that problem anymore. We did have that problem a couple of years ago, but now it's getting buy-in for the surgeons. Some of them say, I only do a specific kind of case and I don't want to fill it. I don't do cabbage, so I don't want to fill all that out. And so we do have some resistance at both junior and senior level. And so we do the best we can. And it's a work in progress. These are paper-based sheets. They're not in Epic. And I don't know that we did try about 15 years ago incorporating sort of an operative note, a very structured operative note in the EMR prior to Epic. And it just did not have high compliance. And so we're paper-based right now.
That's good to know. And the surgeon buy-in, I'm sure Dr. Whitman helps a ton with that, but I think that's part of the whole thing, is that we have to all work as part of a team.
And what's really nice is we have quarterly M&Ms or meetings. There's one with cardiac surgery and anesthesia, and there's one with cardiology and cardiac surgery. And then there's one with, we have STS data is presented multiple times to the different stakeholders. If there is an issue with an antibiotic that's documented post the incision time, we do a deeper dive. It doesn't happen very often, but sometimes it's really, it was documented incorrectly.
Isn't it? Yeah. And it's amazing how you catch those, right? And then why did that happen? And sometimes it opens up a much bigger can of worms about when you realize why it happened, right?
It's we're all human, and there's emergent situations, and the system could be down or whatever reason. But all the NQF measures, our data managers are really on top of that. If beta blockers if it's not documented for contraindication, we reach out to them and let them know. So you really need
Yes.
a strong surgeon champion who's not going to be a champion just within the surgeons, but also within the providers and the clinical team. And I think optimizing Epic has been, we actually optimized our previous EMR before we moved to Epic. So we had a lot of the STS fields in our HMP. And we worked with our PAs to develop that. When we migrated from before we went to Epic, it was sort of a rapid rollout of Epic. So we couldn't get all of the discrete fields in. A lot of them were. But even having discrete fields, you really need to make sure the providers understand the definitions. And you have to go by what's documented in the EMR because of auditing.
Yeah, that's a tricky part, but it sounds like you have a well-oiled machine because a lot of people have worked together to make it that way. So
Yeah,
super
I
impressive.
think the success of our program are really the data managers. They do an awesome job and a very thorough and comprehensive job, and they're embraced well by the surgeons. Although when they don't do this, the surgeons don't do the worksheets. That's a topic of discussion. So it's a work in progress, but we use our data a lot. So we do a lot of quality projects and a ton of research projects. And so we need to make sure that we have a platform to support that. Extracting data out of Epic and linking it to registry data, that's a lot of work. And by having custom fields in our STS software, that enables us to bring over that encounter level linkage in terms of the admission and the operation. Whenever you want to look at intraoperative data or anesthesia data, it's very easy to produce a data extract for research and quality and even operations, in terms of OR efficiency. We can really get data out of Epic pretty easy now.
That's pretty cool. That's really great. Okay, I'm going to go through a couple questions because I think we're getting close to time actually.
Okay.
Are you able to share your slides, Diane, or are you okay did you want to share? Are you able to share your slides? I guess I should ask.
I want to get that checked out first, just because it's our real data. There's really, what's public. We publicly report our outcomes on STS. So the data is publicly reported, although the STS public reporting website, I think only goes up to 2021, and I've shown 2022 data. But I'm happy to share, just reach out to me and I'm happy to select out some things that I can share globally.
Okay, thank you. Are your graphs displayed in, you use Tableau, right? It's Tableau.
So we do use Tableau from what I showed you. We also use Power BI. We have a pretty robust transplant portfolio. We have Phoenix in Epic, and when we moved to Epic, there was a lot of time and effort to really roll out the Phoenix module for transplants. We don't report transplant quality metrics in Tableau. We report them in Power BI. The institution is, had adopted Tableau, but Tableau is expensive. And so with Power BI around the corner, we actually have an enterprise roadmap of what should be developed in Power BI and in Tableau. So we do both, but primarily for quality. Since we started in Tableau, that's where we stayed, but all of the code for Tableau can be ported to Power BI. It's the same framework, just a different, application.
It's wonderful when things work out that way. Your dashboards, do you share it on the units and ICUs for the staff nurses to see?
So Dr. Whitman is the quality director, and so meetings that he attends, he shares it. I don't share it unless I'm invited to one of their meetings, and then I'll review it. But we are opening up our dashboards for unit managers to have access to.
Oh,
So
that's great.
yeah, so it's a
That's great.
blended approach. You know,
Yeah.
we don't allow at the moment in certain venues, it's unblinded. You know, the dashboards are for quality, so you have to be careful that you understand and you pay attention to what you're looking at, especially if you're going to compare the data with Vizient data. The cohorts may not be the same, and the metrics are not the same. So you really need to make sure you're clear, and when you compare the two, the audience is aware of that.
Good points. Do you use the STS extubation timing for your dashboard?
Yes.
Thank you. Does your perfusion have, does the perfusion team at Hopkins have access to the Epic module for documentation? Are you able
Yes.
to get, okay, you're able to get data directly from their documentation into your dashboard?
Okay. So we do not have the Viper system or Spectrum where it connects the actual perfusion equipment to Epic. We do have that for the pediatrics that just rolled out in
My gosh,
June of
that's
this
so
month.
cool.
So we do have that. It's very expensive. And so we are doing that. You know, like I said, this is just rolling out this summer on the ped side. But when we launched Epic, we wanted to make sure all of our documentation was in there. So anesthesia and perfusion is all documented in Epic. And it's wonderful. It's
Yeah.
absolutely wonderful to have, you know, that data available. And what you see in Epic, you know, is Epic only reports at different intervals in time. But when we go into the back end Clarity system, you know, we can pull minute to minute values where you can't always see that. It's actually in Epic, but when the Epic displays the flow sheets, their granularity is not at the point of, you know, every data point collection period.
So that leads into two questions. How does the data get into the dashboards? The STS data get into your dashboards? I think you may have explained that.
Yeah, so we basically export it out of our ARMIS software into a simple Excel file. We make sure that, you know, like I said, if you're ever going to link it to EMR data, you need to have those linking the hospital admission encounter and the op time encounter. But if you're not doing any linking, just our readmission database, we just decided what fields we wanted to export out of ARMIS. And we put it in an Excel file, and the Tableau developers just pick it up, and it's automated into Tableau. I mean, they design the dashboard, they link the visualizations to that Excel file. It could be a SQL database. Some of those dashboards hit directly against the SQL tables, and some hit against an Excel file.
Pretty fancy. You got pretty fancy stuff going on over there. And this is a comment that came through regarding how was the STS data collected into your vendor software? Is it automated, or do you have somebody abstracting it?
It's both.
Okay.
So what happens is we wrote SQL code to go into Epic, into the Clarity, and Clarity is a reporting database that sits on top of the transactional system. That's always one day behind. And so we wrote code, and we identified the data managers and and the programmer identified what fields we felt could be easily imported. And he wrote the code, and it's pretty extensive. I have a whole slide deck of the code and what it does. It's very complicated because, again, you're mapping EMR data to the STS specifications. And then it's collected into actually 3 files. And then those files are uploaded to the vendor, and then we get a report back that they were complete. And then the data manager opens up the software and picks the patient, and they know the patient because they have a patient list from the case list, and they're assigned to a data manager to abstract. So I would, if my name was on the list, I would look for Diana Leho, and I'd take that MRN and I'd copy it into my STS software, and it would pull up patient A. And then I have data managers have 3 screens, 3 monitors, and they have their STS on one, and they have Epic on another, and then they have our scan sheets on the network drive where the surgeon sheets, they could look that up, or they could look up the data dictionary, or really the training manual. And so they basically, they know where we pull the data out of Epic, because there could be multiple sources of data in Epic for the same data. And we sort of came up with what our standard operating procedures are going to be for where we're going to find that data, and what our data managers feel is the most reliable and high quality. And then, they go in and they open it up, and they decide whether it's an index case or not, and they complete the chart.
That's wonderful. Okay, thank you for sharing and clarifying. Are you willing to share the surgeon worksheets?
Yes, absolutely.
Oh, thank you. So, and just Sarah, just to clarify, she said she thought that all surgeon worksheets had to be scanned into the medical records in order to be used. So if that is what the guidance is from STS on surgeon worksheets, is that if that's the only source of information that you're abstracting from, and it's not found anywhere else in the chart, then it needs to be signed by the surgeon and scanned into the medical record. And that's for auditing purposes. If the information is located in other places, and typically it'll be found on the operative note, if it's already located there, then there's no reason to scan the medical record or scan the surgeon worksheets into the charts. It's more just to ease the data abstraction. Diane, at Hopkins, what do you do with the surgeon worksheets?
Yeah, that's an excellent question. So our data managers do not have the ability to enter any data into Epic or scan in documents into Epic. And so our surgeon worksheets are scanned into a secure network drive. They're authenticated access, and they're stored there. And they're used as a tool to help abstract and understand the operative note. They're not part of the medical record. If an auditor wants to see them, they're there, we keep them, but they're not scanned in as part of the medical record.
Thank you. 2 questions. Oh, first, Diane, what is your contact information? I should probably put it on this slide. If you're okay.
Yeah. It's D. Alejo.
Oh, hold on, I'll get it. Because then I can post my my slide deck. Okay.
At jhmi.edu.
Okay, thank you. Okay. And then that way I don't have to email you and say, is it okay if I share your email like 5 times?
No.
Does the coding, hold on. Do you have a few more minutes, Diane, or do you need to
I
go?
do.
Okay. Do you count by procedure date or by discharge date? Do you do your count by procedure date or discharge date?
I would say 99% of the time we go by surgery date.
Yeah.
Sometimes when we're asked to pull data for a particular purpose, like a managed care contract or a specific research project or whatever, a lot of hospital metrics around discharge date and the administrative data set, we will pull data, but we do not report in our dashboards on discharge date. We made a fundamental decision that, it's going to go around surgical date.
Yeah, we do surgical date in the STS too.
Yeah.
Do you have any dashboards that show the star rating fields?
The star rating fields? Well, we do have the one dashboard I showed you where we actually take a copy of the graphic from the IQVIA platform and we update that every 6 months of our star ratings. In terms of the metrics that go into the star ratings, mortality, yeah, that's included in our M&M meeting. We do review that.
Okay, thank you. The data that is produced weekly on Tuesday nights, what is the goal of your abstractors in completing cases prior to producing the reports? Like, are all discharges through the previous Friday completed?
No. So our STS abstraction is retrospective and by weeks. But in order to generate a weekly dashboard, we have to take the prior week's cases and code them into the buckets. And then that coding sheet is an Excel sheet that links to all of the other extracts, the lab, the flow sheets, the temperature data, the chest tube data. So all of the EMR data is refreshed based on that weekly list. And on Tuesday nights, the whole thing is refreshed on a Tuesday night. It's all sort of automatic. So the abstractors are not abstracting the record. What they do is they look at the prior week's cases, and in the Excel file, they'll say, is this isolated CAB, isolated ABR, heart transplant, lung transplant, things like that. And then the dashboard uses that cohort list to pull the data on those patients. That's automatic. It goes out there, it gets the list, and then it presents it in the dashboard. And all of that is automatic, but we don't refresh all of that every day. We refresh it once a week because it's a lot of data. It's a lot of flow sheet data. It takes time. So everyone knows the dashboard is updated on Tuesday nights.
That's pretty cool. And are the PROC IDs, is it the data manager picking out the procedure type and putting them in buckets, or do you have the procedure identification chart programmed in?
We do not have it programmed in.
Okay.
We tried that. It can be close, but no cigar.
Yeah.
So no, the data managers, they code it. And now there might be a case where that has to change, where that will change after they do the full abstraction, or if for say the op note is not done, but the op notes are pretty much done the prior week. So that'll be updated when they finish the chart and sign off, but it might only be one or two off. So there might be something that was called an isolated CAB and now it's not an isolated CAB after the case is abstracted. But know that this Tableau dashboard is for quality and signaling. It's not precise like STS. Our STS data is 100% abstracted, adjudicated, checked or rechecked. So this was a feat because a weekly M&M is a lot of work.
It is a lot of work. And then you have quarterly M&Ms with everybody else, right?
But that's just really a summary of the quarterly STS report that comes out. But we really Dr. Whitman really wanted to see signals and changes. And so the only way was to do that manual assignment of procedures.
Okay.
Yeah.
Okay. And two more questions for you. We want to input perfusion data into Epic. Do you have a pre-designed program within Epic?
We have the perfusionist document in the flow sheets in Epic. So we do not have any predefined. We especially on the congenital database, we worked with the Epic team to modify Epic to make sure we were getting all of the fields that needed to be collected. But there's a flow sheet in Epic for perfusion and anesthesia. And so they just document in there.
Great, thank you. Does the code, and then this is the last question. Does the coding need to be redone every time STS does a version upgrade?
Yes.
Yeah, I can only imagine. Did you do it between 2.9 and 4.2, or is this?
Oh, yes, we've done it for like 3 versions now.
Oh my.
It's really not that bad. But yes, we have done that. I think maybe 4 versions. I know at least 3 versions. We've
Yeah.
had to do that.
281 to 2929 to 42.
Yeah.
Yeah. All right. Well, that's it. Those are all the questions. Thank you, Diane. Great presentation. We always love hearing from you. I want to make you join every webinar to help answer questions. But
well, I hope I was on target. I know I showed a non-STS, metrics, but this is
oh,
really.
that's okay. It's a quality improvement, and what's important to Hopkins is likely important to other sites as well. And just the ability to share the information among 1,000 hospitals. We had almost, I think, just over or just around 300 on today. So just to get information out to everybody, show ideas, and talk about quality improvement is the goal. And that's what you did.
Well, thank you.
Yeah, thank you. So thank you so much. Our next if you need to reach out to a Diane for slides or the copies of her surgeon worksheets that they use, her email is dalejo, ALDALEJO@jhmi.edu. If you need to reach out to me, I'm ckrohn, KROHN @sts.org. And our next upcoming webinar is on August 2nd at 2 p.m. Central. So thanks again, Diane, for joining. Thank you, everybody, and I hope you have a great rest of the day.